Okay, implementing the comprehensive spending review in home care for older people. And as was mentioned, you've not got to look far to realise the implications. Just in some of the newspaper cuttings that I Googled earlier in the week, some local, some national. You only have to turn your papers on, your telly on, local or national news, whether it's your local library or the scare stories about closing day centres or whatever. It is certainly clear. But it's interesting, I mean, first reflection really is that it is actually only now, when the financial crisis hit in the autumn of 2008, today is when people are sitting around in their local authority chambers making the decisions about what to cut. Interesting reflection in itself. What makes this system complex? I suppose there ought to be a prize for who's presented and convinced the audience about the complexity of their problems this afternoon. But clearly in this sector, in the care sector, there is a complex mix of the socio-demographic changes that are going on. You need to add some of the local flavour in terms of emotive and societal expectations. It's my right. This is cradle to grave. How dare you take these services away from my mother? Type language. And add into that the dose of political, local and national ingredients, particularly when previous said person writes to their local MP. You get an awful lot of interesting dynamic going on. Not that we can model every element of that, but the challenge for a senior manager who's making these cuts to justify it and say, actually, we've thought hard about this, and we're not just doing it willy-nilly. Although you will hear that challenged, and certainly in our local environment up in North Yorkshire, then there is a legitimate challenge in some local authority council chambers where they don't know how to think systemically, I suppose, and they are just taking a slash and burn approach, which might also be a comment on the extent of the challenge. So I want to talk to you about North East Lincolnshire. It's a little bit away from here. North East Lincolnshire, you have here, top left, some chemical works at Immingham. You have the seafront. From the aerial view of Cleethorpes, that wonderful seaside resort in the northeast, and a little bit closer up there on the bottom left, and the Grimsby Docks Tower here in the right. A very sort of proud northeastern town, but quite away from a lot of other places actually. It's 30 miles fast on a motorway to the nearest town of Scunthorpe, and just similar distance to Hull. However, despite its isolation, it's an organisation that we've worked with and that is nationally recognised as being at the forefront of integrated commissioning and delivery of services. It's recognised as a care trust, which means that health and social care have been brought together to work as a single senior management team and actually to work that through. The italics here, I won't read them out, but that is a quote. Those aren't my words. That's a quote from the Director of Integrated Commissioning about the value and the benefit of using a systems thinking and systems modelling approach. So I think you'll see there that here is an organisation that's becoming used to thinking in this sort of way. Moving on to home care itself is one part of the challenge. The part of the local council that I'm working with is social services, so we haven't necessarily got the challenges of libraries and road maintenance and other elements, but we do have a system that's quite complex, of which home care is one element. So we're not here talking about the care home sector, residential care, although they're clearly linked. So it does represent one sector. Just to give you a flavour, the local savings targets, the population of North East Lincolnshire, I should have mentioned, is about 170,000. So it's not huge. 5.2 million cumulative over 2 years. That's the way in which the comprehensive spending review at the moment is being described in terms of a 2-year programme. Partly through savings in home care. So this element is one contribution to that 5 million. But you'll see here, whilst reinvesting in preventative services, for North East Lincolnshire, it's not enough just to cut, because they recognise that's not a sustainable long-term solution. And so what they want to look at is a much more dynamic system that says, well, if we are shaving some money off the system how do we ensure that that doesn't come back and kick us in several years' time? So how will this impact on different groups of people? Is it sustainable? Are the sort of questions that they're raising. The project that this represents is a reflection of a lot of the discussions and presentations that you've heard this afternoon, in that there will be, in my mind and in the mind of the senior client, a process of issue identification, exploration, analysis, testing out of conceptual models and gradually building a model. But it's a little more embedded, so it's not quite as explicit and visible, if you like. It is the process that's used, but there's an element of it being embedded, although I remain a sort of external expert advisor and modeller. But this is the model conceptualization, where we've got a certain number of clients, certain number of contracted hours. They have some information around what that means in terms of average for each of the clients. And what they're actually looking at here is the transition process at the same time as reletting contracts on a neighbourhood basis. So they're actually moving a significant number of people, a caseload here, predominantly what they call a just checking service, which is basically people eligible for home care, but won't receive a traditional package of a certain number of hours of somebody going in and doing things. It'll be a little bit of a step back. And you'll see here how they've conceptualised and how they've asked questions in terms of what's a reasonable split moving across and changing that system. So that was the conceptualisation. The model logic, which was fairly easy for them to understand, is that they visualise an initial stock of people transferred to a new provider at the start of a new contractual arrangement, and that's happened in one of 5 local neighbourhood areas and will be starting to roll out over the next few months across the rest of the northeast of Lincolnshire. They're then looking in that renegotiation of a contract to, in effect, top slice 10% of the value of those contracted hours to invest in prevention, and that's their mechanism, their lever, to secure that ongoing investment. They recognised in the model conceptualisation, although they might not have described it initially, the importance of that transitional period and the quality of the transitional period, because you're not just going along and reassessing an individual and saying, well, sorry, Mrs. Jones, tomorrow you won't receive your home care. They're actually going in with a reablement package and saying, well, actually, we think we can work with you to achieve better outcomes for your independence, your integration into the community, and then we will reassess at the end to see exactly what's happening. So the transitional period is important conceptually for them from a quality perspective and from, I suppose, a moral and social responsibility perspective. And what that does then is force the development of a new mix of support. And what you've therefore got associated in the language of health and social care is a market development process, where they're actually looking, and it fits in with big society, though they wouldn't necessarily use that language in North East Links, but it fits in with lower level services, social enterprise, local communities, networking and supporting individuals. So I've mentioned process was fairly standard. We did some analysis, we understood the trends, we engaged, shared the models, and then informed final policy. A couple of snapshots. You'll see this is built in your first visual of an I think model this afternoon. We've used I think. You can ask me later why. And here I just got 3 screen shots just to illustrate the sort of policy options that they were investigating. I'm not going to show you the detail of the model, although quite happy to share it with you outside the room. But you'll see here on the left-hand side, there's a rollout programme. There are 5 neighbourhoods. And they wanted to see, because they needed to accumulate savings over a particular financial year, capture that and see whether it made how much it contributed to their £5 million target. You also have going on at the same time a contract negotiation process. So this is the price per hour of home care that they're able to negotiate. And you'll see there's some initial and some target prices. And you've also got an interface there, and it's flat at the moment, but it was an ability for them to explore the impact of cost recovery, because as you're probably aware, within social care is means tested. If somebody has resources, they make a contribution. and there's a certain percentage, I think it's 21% or so, that historically has been recovered, and what they wanted to do was to explore what the alternative scenarios were had they been more thorough in terms of cost recovery. So that was one set of inquiries. This represents, it's more important conceptually than sort of vision in terms of what the detail is there, but what we were doing was calibrating back. That question was asked earlier as well. We calibrated back 2 years, so in effect to April 2009, where we had some data. We were following the trends and trajectories, and therefore the first part of some of these, you'll see that there's a change and then a levelling off. These were extremely important in enabling people, and I'll flick on twice actually, and I'll go back to that one. Because in terms of the output, what they were experiencing, what they were learning was the effect of a lag in the system. Because the blue line here is the number of people receiving home care. And you'll see there it's fairly level. You've got to go back. You've got the timescale of 5 years across that graph. So the last 2 years, we're almost sort of near the middle of this now. But you'll see that the number of people receiving home care was fairly flat. That's the blue line. What they didn't realise was the total cost was still rising. Because what was happening within the social care assessment process was that they'd been told by their management to be, and I'll use these words advisedly, more strict, meaner, whatever, not allow so many people into the home care sector because they recognised that there were cost pressures. But the social care workers were often then overcompensating in their generous spirit and actually giving those people more hours. So it's saying, well, actually, if it's less people, they must be more needy, therefore we'll dole out, and it overcompensated. So the actual costs there, the red line and the, whatever it is, pink line, the bottom line, reflect the actual cost. And that sort of delay in the system was one of the key learning points. And it was partway through that certainly the senior executives within the sort of system that we were developing sent a big sort of red message down the pipe in terms of saying, look at what you're doing in terms of the size of packages that are being delivered. So that's why that's important. This is an illustration because they also wanted to explore it's a sort of last-ditch effort in terms of what would we do if we actually introduced a waiting list for some of this home care. Now, they recognise that it's pretty risky business if you go out to somebody who's at risk, needy, in the community, and you say, well, yes, you need a certain package of care, and whether explicitly or not, you'll have to wait a little bit, because those people will be at risk. And in terms of whole system thinking, they recognise that those people could bounce in and out of hospital a few times, and it's not good both for the quality of care and for the costs of the whole system. But they did recognise that people on lower levels of care often come to services and they can be in receipt of a package of care and then actually improve in terms of their functioning almost naturally without the need for that care to continue. And social care is pretty bad, typically, about reviewing. And so what they were trying to do was explore the impact, and the sliders there illustrate that they were being sensitive to the level of need. So they weren't going to put a waiting list on people with high-level complex need, but they were going to potentially, they wanted to explore the benefits of instigating a waiting list at the lower levels of need. The graphical interfaces there, which you'll also see are different, were about the risk of a crisis event and a hospital admission, depending on the level of need, and that was all quantified within the model. So those were the sorts of experiments, those were the sort of issues that they were wanting to achieve. I've explained what that graph describes there, and the outputs, what they wanted to see at the end of the day, with all the other sort of caveats and assumptions, was this sort of output in the table here. Our 2009-10 spend on home care is about 7 million. You'll see there it goes up to 7.6, which is the implication of the rising red line. How then do we start to claw that back, and what contribution does it make? The second graph was actually the final graph, because we then rebased it. The previous one was 2009-10 base. This is rebased on 2010-11, because that's what they will be judged on. And you'll see there we've got a contribution, depending on sensitivity and analysis, of around 1.2 million, 1.3 million. So we're starting to provide them with an indication of what contribution the home care element makes to this £5 million worth of saving over the first 2 years of the comprehensive spending review. That wasn't enough. And what we're currently doing, is a slight sidestep for a moment, is linking this model with other modelling that we've done around care home and the intermediate tier. Intermediate tier is around reablement and enabling people to actively reabling and rehabilitation. And part of the consequence of doing this model was to look again at some of the performance within the reablement and intermediate tier sector to really push that, because whilst they'd redesigned it about 12 or 15 months ago, and they weren't aware of it until we did this modelling, the effectiveness that they'd expected to come out of that wasn't being realised. And the reablement system will in effect accelerate the reduction in the red line further. Whether they can do that now in time to affect the savings over 2 years is up for debate and is still being modelled. So a couple of comments in terms of local learning and what benefit this has been in terms of applying an SD approach within this sort of area. Current service uptake doesn't necessarily equal needs. That's really just a reflection on that point about you might be assessing fewer people, but actually you're compensating in some way. And it's need is a very slippery concept within health and social care because it's so determined by perception and comparison as well, both historic comparison, what have I always received, and geographic comparison. So very slippery, and to do some analysis that says this is the uptake and equate that to need is probably not a sensible thing to do, and that was some of the learning that came through. It's a fairly sort of general comment. Gathering the intelligence itself and informing the ongoing refinement of the policy and implementation is vital. This was, and this has been emphasised throughout this afternoon, it is an iterative process and you're learning as you're going along. Be interesting to engage in that debate about how much data do you need to make a model that's useful. I think that's a very interesting, but you do need to gather that intelligence. And if you can feed back from this model, a type of modelling work, to improve the collection of different types of performance data, your point, Kim, in terms of nobody collects flows. I'm on a mission to encourage health and social care organisations to collect information on flows, and I've started. Third point there, you really can't stop the world to undertake analysis. In fact, that was some of the conversation over coffee with somebody. The health sector and the social care sector is moving very quickly, and had we started that modelling on sort of, well, what do we know on April 2010 or even April 2011, we wouldn't have got the true story. Things are moving. The fourth bullet point reflects back to that waiting list, and I didn't have time to show you how that possible policy impacted, but when we did work it out and play it through, it was short-term and ineffective. Don't do it, and so they didn't. So that was key learning. And in terms of focus and attention in an area that everybody thought had been fully implemented is a comment on that reablement sector, where they thought they'd fixed it. When they looked at an adjacent sector, if you like, they thought, well, actually, what we thought we'd done in reablement hasn't really had the impact on home care that we expected. Let's go and revisit reablement. In terms of transferable learning, embedding system dynamics approaches within an authority, that's a challenge. And it's not easy. It follows people, and we've had those experiences and described this afternoon. But I think there is a sort of cascade and it's a dissemination process. I feel something going on in terms of people's awareness of SD. But actually, the investment, I don't think North East Links could have done this work in the last 3 months had they not spent the last 2 years exploring this sort of methodology And having somebody actually who I would reckon is a guru in systems thinking without knowing it and without being able to model. Because there are people out there like that, and I'm sure you've come across them. And the importance of strong relationships and trust between participants in the learning process. Here we have an integrated outfit that's relatively young in terms of 2 years of people working together from very different backgrounds. Health and social care do talk different languages. But SD provided them with an environment to share and learn together. Final slide, pretty sure. We are currently working to integrate this model with a number of other models to develop a broader system. Those are some of the components. And what it's doing at the moment is providing an evidence base and actually informing a program plan with quarterly performance targets that will include flows for April 2011 forwards for 2 years. And we're currently writing that document with them so that it's underpinned by a whole system perspective, underpinned by the sort of insights that we've seen this afternoon, but then enables people to really program manage the change, use the model just on a periodic basis. So it's certainly not an operational model. It's not something they'll look at every week, but it is something that we'll use to validate their progress over the next 2 years in achieving the sort of savings that they need to. And that's it. So thank you very much for your time, and I hope you found that useful and interesting.